Over many years, I get patients coming in and saying they've been told that pain is all in their head. Is this true? And what really is pain? And most importantly, what can we do to help? Well, we are going to try our best to explain the current best understanding of pain in this video. Another issue people have is trying to get scans or imaging for body parts to diagnose what's going on. Back in the day, it used to be routine, but now it's becoming less and less common in practice. So why is this? Well, to start with, there are different types of pain. Sometimes this is labelled as acute or chronic or inflammatory, but to better explain it, we can split it into four different types. And we'll explain each of these. And they are nociceptive pain, nociplastic pain, neuropathic pain, and the fourth is where some of these are combined. And a big thing to take away from this is that all pain is real regardless of which that is. And the reason I know this is because I suffer with one of these pains. And this is why I've taken such an increased interest into understanding it. And I'll explain which that is in this video shortly. But before we explain those, let's look at what pain actually is and how the understanding of it has changed. We can take this with the idea that if you'd cut your arm off, we'd all agree that is painful. You will have receptors, sensory receptors, thermal, mechanical, chemical, which will detect this change in tissue. Now, if we talk about nociceptive pain, this can be either acute, so short-lasting, or chronic, which is longer-lasting. Again, more complex than this, but you can imagine is that these receptors then send a signal up to the brain will interpret it and then send a signal back down, and that's what will create pain in that area. And the bigger the damage, the bigger the signal. As things starts to heal, there's less signal up, so less signal comes down, and therefore less pain. And this continues until no signal goes up, so no signal comes down, and the pain goes away. So what we know then is you need a conscious system to be able to interpret the signal and therefore experience pain. And I'll explain this in another way using the eyes as an example shortly. But to explain the need for a conscious system, let's imagine you've cut this arm off and you've put it on the table. Will you feel pain? Well, yes, a massive amount because you've got a massive amount of tissue damage. Those signals will be sent up, telling the story of what's happening, and then a big signal will be sent down, lots of pain. But what about the arm on the table? Does that experience pain? Well, no, because it's not connected to a conscious system. It has just as much tissue damage, but no pain. It's just a lump of meat at that point. There is no brain connected there to experience the pain. So this moves us into the next type of pain, which is a nociplastic pain. This can also be referred to as a central sensitization, a type of chronic or persistent pain. This is using the same system. However, what can happen this time is that the signal up and down doesn't work the same as a nociceptive pain. A lot of the time it can start as a nociceptive pain. With an injury, the signal comes up and comes down as it would before, but as less signal goes up, when things start to heal, the same amount of signal may come down, so the pain doesn't decrease as it should. And this can carry on, so a tissue may completely heal back to normal, but signal is still going down and the pain remains. We can see this classically with phantom limb pain. Someone will have pain in a limb that is no longer even there. And this is where the analogy doesn't completely work, because the signal can't go down to the limb that isn't there. But in the brain's map of the body, it can. So again, it's more complex, but this is just to help explain the idea of what's going on with pain compared to the mainstream understanding. It can also be affected where the pain may reduce, but the body is on high alert. So a small signal up can end up producing a big signal down. So a high pain response from a small input. And a lot of the time, as these neurons are firing to deliver the pain response, they get better at doing that. It gets quicker and more effective, and this is where pain can become more persistent. This can also happen the other way round though, where you could have tissue damage and a signal up, but very little or no signal comes down. A lot of it comes down to threat perception and the interpretation of the brain for how much it needs to let you know about this pain in order to protect you. And this is where the reliance on scans for diagnosis can fall down, because they can't show you pain. And seeing the level of tissue damage doesn't always correspond to the level of pain felt. You can't measure pain, you can't have a scan or take a blood test and be given a pain score. A lot of studies show that people with tissue changes have no pain, And sometimes people with nothing on a scan can have a lot of pain. And it's mainly those that feel dismissed and that it's all in the head. But that is just what all pain is. This signal down, and it's all very real. And this is where sometimes those scans can actually be negative and increase pain, because they can increase the perception of threat, especially depending on the language used by the person delivering the results. If someone says, especially a doctor saying, "My God, you've got really bad degenerative changes, things are crumbling and torn, and as bad as an 80-year-old, that will massively feed into that fear of protection system and make pain worse. I think the problem at the minute, though, is it's now swung the other way too much, and we aren't scanning or getting images enough. Scans can be a really useful tool, not to diagnose exclusively based from it, but definitely to aid in it. And as long as this is explained to someone in a non-threatening way, it can be extremely helpful. So we need to find a middle ground on this. The other type of pain is a neuropathic one. And this is basically nerve pain, and a lot of the time is referred pain. A classic for this is sciatica. Your nerve may be irritated at the back, but you feel it in the leg. There's actually nothing wrong with the leg, but that's where the sciatic nerve goes, and there is a signal coming up from that sciatic nerve because of the issue at the back. So the interpretation, and therefore the signal down, is that there's something up with the leg, and that's where a lot of the pain can be felt. The final type is some combination of these pains. A lot of the time it will either be nociceptive or neuropathic with nociplastic, especially if it's been going on for a long time. So I mentioned that I suffer with one of these pains, and it is a combined of nociceptive and nociplastic. So when I was younger, I was helping my dad out in the garden, trying to get some weeds and plants up, and I was proper yanking on one with a massive root, and it just wouldn't come out. I was trying and trying until eventually I felt a really intense pain in my mid-back, the thoracic area. My back gave up before the root did, and I've suffered with this pretty much ever since. Almost about 15 years or so with different intensities. What had happened is that a disc herniated and is touching my spinal cord, so now I'll be getting a signal up because of that touching of the cord, and the signal down with pain to let me know about it. Because these signals have been going on for so long, they are very robust and likely some nociplastic and sensitization coming with it. And that can be what typically happens with things like arthritis. With the back though, a lot of that comes with muscle tightness and spasm. Quick wrong movement of the body, and it will respond with tightening more muscle to protect the area, and then more pain. But this will then settle as it's not needing so much protection, while the original pain remains. A lot of people will find this really common with the lower back. Even though the nociceptive pain may have resolved and you have no pain for a bit, sometimes maybe years, you've got no signals up or down, but that protection of the area can remain. So if you've had a previous injury in an area, a certain movement and the brain overreacts with protective muscle spasms. It almost locks you up so you can't move. It can be really intense and painful. A lot of the time with this, there isn't any tissue damage that's occurred, but a memory in the body to help stop future damage occurring. The smallest signal up with a strong signal down for protection with these muscle spasms, which then sends its own signal up and even more down. Really not nice. It's the signals from receptors, interpretation from the brain, and then an experience of pain. And this, a lot of the time, is the use of language where people may think they've been told it's all in the head. It's not that it's in the head, but it comes from the head. We can use the same example with the eyes by saying you don't see with your eyes. Again, it sounds ridiculous, but it is true because you just receive light into the receptors in your eyes, and it's your brain that interprets and creates the image and the experience. Your whole world is really just in your head, interpreting all of these signals. It's the same with hearing. You don't hear with your ears, you just receive vibration signals and your brain creates the sound. Taste, touch, whatever, all the brain is no different for pain. But this does mean that more factors can affect pain. It's not just the size of tissue damage that dictates the size of the pain response, but it also means more things can be used to improve pain. So it's not just about treating the tissue, but also taking a wider view of what can help. So movement generally is a great one to help, not only for the general health, but also for reduction in threat perception. A classic example of this in action is stretching. Say if I was going to do the splits, which I can't, But I would get to a certain level and then things would tighten up. A signal up from the receptors about how much a joint is moving and the tension is on the muscle, which causes the signal down to tighten the muscle to stop that movement going further because that isn't deemed a safe movement. Because if going beyond the range you typically go into, it will then tighten the muscle, protecting you. Obviously, if I just force that movement, I will hurt myself and cause tissue damage, which will cause pain, potentially. But if I tease it gently, consistently over time, gradually doing more movement, it's basically the signal down going, okay, yeah, that seems safe, we've done that before, and it allows a little bit further movement and so on, until I can then do the splits. Well, this can work for all areas to desensitize movements and allow for more safer ranges. So a lot of the time, avoiding a movement because it's painful can make things worse because the interpretation is that they aren't safe and the pain remains for protection. This can be tough though because, like mine, a movement might cause the disc to press more on the cord and can actually be increasing that nociceptive pain. But there will be a lot of protective tightness around where I do want to keep moving into. So that range increases over time and doesn't reduce. So a lot of testing is needed to see if that makes pain and range better or worse. So we know exercise and movements help. Again, likely to do with the tissues, but also likely a lot to do with the brain and its perception of danger with movements. And because the brain plays such a big part, it means there's so many other areas that can affect, but also help. How well you've slept, how stressed you are, do you enjoy your job, what's your relationship like with your spouse or friends, what kind of environment are you in, and do you like that environment? Do you have money troubles or stresses? What's your general mood like? How do you see the world? Have you had any deaths of people close to you? But even other things, are you nourishing the body well? Is there a lot of inflammation from a poor diet or foods that specifically affect you that will impact your body and brain? How hydrated are you? Sometimes improving any of these can help. So pain is much more than just something being wrong with the tissues of the body. And there's likely still so much we don't yet know or truly understand about it that will come out in years to come and will help with better treatments and managements. My prediction will be some kind of neural interface with the brain, and then you'll just be able to turn it down on an app. Don't know in our lifetime, but the rate things are progressing at, you never know. I really hope this was useful and just gives a bit of a better understanding of what we currently believe the different types of pain to be.